Okay, well, we might get started. There might be a few people coming in along the way during the presentation, but we have Cherie Ziski sitting in the background going to assist anybody who's got difficulties with joining. So welcome, good morning, good day, good evening to those of you, depending on where you're joining from around the world. And welcome to our 5th International IOP webinar based on school-based physiotherapy. We have some really exciting speakers for you today. So let me just move on to the next slide. Hopefully the slides will work today. So we have Dr. Eda Cinar, who's a postdoctoral fellow and school-based physiotherapist working in Canada at the moment. We also have Dr. Kirstin Macdonald, who is a member of the IOP Research Committee and the school-based physiotherapy group with the IOP. And we also have Dr. Connie Johnson, who's a member of the IOP and the school-based physiotherapy group too. So each of these speakers have a wealth of knowledge around school-based physiotherapy that they're going to share with you today. And we'll have some time during the presentation for you to ask some questions, but more so some focus time right at the end, where we'll run a couple of polls for you to offer some feedback for us about different things related to school-based physiotherapy. And also for you to then ask some more questions, open-ended questions at the end of the speakers. Just to let you know, this presentation is being recorded, but the recording and the slides will not be available until after the World Congress later in the year. So later in May or June, so around mid-year, you'll see those released, and that information will then be posted on the IOP website. So we know we've got members coming in from all over the world. We have a fairly large group coming from Australia, but probably based on the time that we're presenting today. But we also have people from many different regions of the member countries of the IOP from around the world. But before we get started, because we're joining you today from Bond University and hosting from Bond University, we'd like to acknowledge the Coomerbury people, who are the traditional owners and custodians of the land on which our university here at Bond University now stands, and pay respect to our elders past, present and emerging. So the purpose of the presentation today is to introduce the IOP members to a range of school-based physiotherapy services that are occurring around the globe, to share evidence-based physiotherapy practices for physiotherapists working in schools. So not just the typical area of school-based physiotherapy that many of us might be familiar with, associated with disability, but trying to extend that evidence base across areas that we may not have otherwise thought about. And also to outline the work of the IOP School-Based Physiotherapy Group to facilitate discussion and identify future work of the group. In terms of our learning objectives, we're hoping by the time you walk away from today's webinar, you'll be able to identify a variety of school-based intervention models, including those that the physiotherapy profession have agreed upon. We hope that you'll recognise the range of evidence-based intervention options for physiotherapists to use in school environments, expanding our scope a little bit wider than what we historically may have thought our role might be in the school systems. And then to utilise school-based physiotherapy fact sheet, which Connie's going to introduce you to assist with advocacy and awareness of school-based physiotherapy services internationally. We know that many of the people who register don't always make it to the webinar itself and might actually watch the recordings down the track. So if you are online at the moment, we have the SurveyMonkey link here for you. If you could go ahead and register your attendance today so that we know exactly who's been online, and we can provide you with an attendance certificate if that's something that you're requesting. You can either scan the QR code there, or you can type in the link and it will just ask for your name and email address and the country that you're coming from in order to get your registration certificate sent out to you at a later date. So I'll just hold there for a moment.
I'll also pop the link in the chat, Nikki, as well now for anyone who doesn't have their phone with them.
Thanks, Sheree. Okay, so a little bit of background to the school-based physiotherapy group and what they've been doing internationally to try and move or progress the agenda of this area in physiotherapy worlds. The International Organisation of Physiotherapists in Paediatrics have actually identified school-based physiotherapy as an international priority area in their life strategic plan and the current strategic plan also. And in 2019, at the World Congress in Geneva, the school-based physiotherapy group met for the first time and developed an actual working group and identified some strategies and some activities that they wished to work on. They knew from discussions at that group and from some prior conversations that there was really varied practices for school-based physiotherapy occurring across the globe. And they knew also that there was no published position statement guiding the physiotherapy scope of practice in schools. So that was probably one of the things leading to a very wide scope or wide practices going on across the world. So the IOP working group identified that there was a need for a position statement or a guide to be, for school-based physiotherapy to guide the scope of practice. And the creation of a position statement was thought by the working group to be an essential first step to guide the development of school-based physiotherapy services, specifically to guide interventions and also prevention and health promotion activities where needs were identified in particular schools. So a number of activities were planned in order to try and get to a position where they could actually write a position statement. And the first one was to write an international IOP newsletter, which showed what the current position of physiotherapy services in schools was like in each of the member countries. So obviously, we couldn't get to every member country, but we selected all the regions of the IOP and made sure there was representation as widely as we could for where we knew school-based physiotherapy services were occurring. Also, a group of the school-based physiotherapy working group undertook a scoping review where they explored the roles, duties, scope of school-based physiotherapists based on what existed in the literature at the time. And then an international Delphi survey was occurring at the same time, which Eda is going to talk to you a little bit more about, where they're trying to gather expert opinion from school-based physiotherapists as an expert panel contributing to that group. And then the IOP fact sheet was also being developed at the same time by the school-based physiotherapy working group. So that is going to be shared with you today from Connie at the end of the presentation. So if I share a little bit about the newsletter, I won't go into too much detail, but I would like to just signpost to you that the newsletter is still available on the IOP website if you wish to have a look at that. And there was a large group of people contributing to this international perspective on school-based physiotherapy services. And so each of the regions looks a little bit like this. It's a narrative about the services, scope, practices, duties of school-based physiotherapists based on what those who were working in the sector or had worked in the sector knew about their local regions and what was going on there. So the website at the bottom of the screen there will take you to a PDF that shows this IOP newsletter. So for anybody who wanted to have a closer look at that, you're welcome to jump onto the IOP website and download that newsletter. Soon after the newsletter was developed, the scoping review started, where we were looking more specifically at the roles, duties and scope of school-based physios based on what was published in the literature. What we did in this in this scoping review was to explore the roles, the duties, the scope, and also service models that were occurring in the school environments. And we then sub-themed these according to how much we were seeing them come up in the literature. So if we saw only one paper or less, then we didn't consider that to be a role necessarily for school-based physiotherapists. But if there was 2 to 3 articles being published on the topic, we thought maybe this is an emerging role for school-based physios. If there were 4 to 7 articles, then we thought that's probably an established role for school-based physios. And if there was more than 8 articles published on a particular activity or role going on in the school environments by physiotherapists, then we considered that to be a consolidated role for them. So I'm going to share some of the preliminary data. This scoping review is being updated this year, and then hopefully it will make its way through to publication. So by the end of the scoping review, we had 111 studies, 7 reviews, 12 policies, 32 procedures, and 17 guidelines, all about school-based physiotherapy in some way, shape, or form. The data that we were gathering was really predominantly coming out of the United States. As you can see, there was far more literature from the United States than any other country. And when we looked to the grey literature, where we were picking up more policies and procedures, we saw a little bit more coming out of Australia there, but also predominantly coming from the United States. So when we looked at the role and the duties, the main duties that we saw from the literature that we were able to gather were the roles around undertaking assessment, planning and goal setting related to achieving outcomes for the children in the schools, performing the interventions, and lots of different evidence about the interventions, non-client education, so not specific to the student themselves, but to the wider group of people around that student, undertaking health promotion, of course, undertaking documentation, and then interprofessional collaboration was a growing area in the literature that we saw. And we also know that the activities for each of these duty headings, if you like, were really contextualized based on the laws and regulations that were occurring in each of those countries, and also any populations or conditions that might have been more predominant in those regions of the world. And those, the laws and the populations and conditions in the school environments were very much driving the models of service delivery because of the environment that those children were in. So if we look here, these are the preliminary results that we've seen so far. I'll just talk through the consolidated column because we don't have time to go through the rest, but what we predominantly saw in terms of assessment was standardized assessments being undertaken, and that was largely associated with funding attached to the children in the school environments. Motor screening and also needs-based screening was occurring quite a lot. In the planning and goal setting area, the physios were very involved with individual education plans and just generally setting goals, whether they be in the classroom or sport or physical education environments. And then in the intervention side, we were mostly seeing intervention being related to individual students, so one-on-one interventions occurring. So predominantly that was the main drive coming out of the literature. And then, of course, enhancing mobility, but again, mostly one-on-one activities going on there. We were really interested to see whether there was more opportunity for tier 1 activities, which Eda and Kirstin will talk to you more about in their presentations, but the wider scope of being able to provide services, not just for one-on or for children with diagnosed disabilities, for example, or conditions, but for the wider group of children within a school environment. And so we were looking with the red areas here, whether these things could be done as whole of school or whole of classroom approaches to the service models. And we think that there was plenty of areas coming up in the red areas here, like enhancing cardiorespiratory fitness, balance programs, health and wellbeing programs, etc., that could be done as whole of school or whole of class approaches. When we looked at the non-client related education, we certainly saw health promotion actually coming up quite a lot. In terms of the health promotion, the biggest thing that we were seeing was physical activity and fun kind of movement programs occurring. For documentation, of course, referrals, and this was referrals not within the school system itself, but referrals to outside of the school sector. And then the interprofessional collaboration with the wider team. What we saw was that team members were mostly teachers, as you may expect, parents, carers, speech pathologists, occupational therapists, domestic and house staff at the school, psychology and special education workers. So they were our larger team. And then in terms of what could be done as whole of school approaches, then we thought that those things coming up in red here certainly could be done as whole of school approaches as well. And then finally, when we looked at the populations, as it was connected to the direct one-on-one service delivery that we were seeing for the service models, we were seeing most of the populations being those who were diagnosed with a physical disability or an intellectual disability. We saw specifically children with cerebral palsy coming up in the literature a lot, and those with developmental delay or concerns or diagnosed syndromes. And then we saw some other areas across those other columns of established and emerging starting to pop up in the research literature also. The environment that physios were predominantly providing their services were in mainstream schools, more so than special schools. And the models of service delivery tended to be more direct, although we were seeing quite a few papers talking about indirect service care, so teaching the physios, teaching the teachers or the teacher aides how to provide services in schools, for example, and then inclusive or integrated services occurring in the schools. So again, we thought that there was plenty of room for whole of school approaches to be occurring, like universal design of learning, etc. So at this point, I'm going to stop and hand over to our other speakers, and that hopefully gives you a little bit of context about what's going on around the world. Eda Cinar is going to speak with you first now, and then Kirstin Macdonald. And Eda is going to talk to you about the work that she's done with the Delphis around school-based physiotherapy. And then Kirsty is going to share some of her research literature that has come about from her PhD thesis, and expanding the scope around school-based physiotherapy to be more whole of school, etc., but also looking at relationships between physical activity and motor proficiency with academic performance. So I will just unshare here and hand over to Eda.
Hi everybody again, welcome and thank you for coming to listen us. And I'm Eda Cinar, a school-based physiotherapist working in Canada. I am also I was also doing my postdoctoral fellow training at Sherbrooke University. Today I am going to present one of our studies about collaborative tiered school-based physiotherapy service delivery model that we have conducted during my postdoctoral training at Sherbrooke University. So we have conducted this study with Chantal Camden and Dana Anabi, and also Price PT Network, who are these are the physiotherapists and then the experts, including the Price PT Network is a network including the experts in the school-based PT. So overarching goal of our project was to develop an international collaborative tiered school-based physiotherapy service delivery model. So when we say school-based physiotherapy, to define school-based physiotherapy, we consulted our recent guidelines according to, for example, Academy of Pediatric Physical Therapy and Academy on Pediatric Physical Therapy and American Physical Therapy Association. School-based physiotherapy, it is not only related services which requires to assist a child with disability to benefit from special education, it is also a practitioner of choice to apply evidence-based practices regarding general growth, development of all students, as well as health, wellness, fitness, injury prevention, and obesity management. For this model, one of the important concepts was the collaboration. So we aim to develop a model of service which is collaborative. So we all know that the collaboration is one of the important elements of for the care of a child. When it comes to schools, collaboration becomes more prominent. And collaboration was identified as the best practice in school settings. And we also aim to provide a physiotherapy services for all students, not only students with disabilities. That's why we adopted a tiered approach to provide services to all students considering their needs. So tier approach takes their roots from educational framework, such as universal design for learning and response to interventions. Universal design learning is a teaching approach to eliminate and remove the barrier from learning process. And it provides different strategies to remove these barriers. So I'm going to show you a short video describing UDL strategies.
Universal Design for Learning, or UDL. What is it? It's a way of addressing the different learning needs of students right from the start, thinking about the diversity of learners and reducing barriers to learning. Diversity could include differences in background knowledge and experience, learning preferences, learning strengths and abilities, personal interests, and levels of engagement. UDL means identifying potential barriers within the learning environment so they can be reduced or eliminated. The result? Increased accessibility, more success for more students. Many Alberta schools are using universal design for learning principles to create more learner-centered and inclusive learning environments. A UDL approach benefits all students, including students with disabilities. It helps blur the line between regular education and special education. Universal design for learning is based on three main principles: multiple means of representation, giving learners different ways to acquire information and knowledge; multiple means of action and expression, giving learners different ways to demonstrate what they know; and multiple means of engagement, tapping into learners' different interests, challenging them appropriately, and motivating them to learn.
So another approach to identify the needs of the students and addressing their needs is response to intervention.
Universal design for learning. Universal design for learning.
The response to interventions start with general instruction and high quality instructions and universal design for learning strategies for all students. When a child cannot make adequate progress in the tier 1 level, so it is at the beginner level, and they are gradually provided with targeted interventions at tier 2 level and intensive interventions at tier 3 levels. So these universal design for learning and response to intervention approaches have been already successfully integrated in school-based services. For example, Partnering for Change was created to provide services for occupational therapy. However, when it comes to physiotherapy, we didn't have any literature who can guide physiotherapists and policymakers to implement such a model into current practice. So to fill this gap, we have conducted 2 studies to develop a collaborative tiered school-based physiotherapy services. In the first study, we aim to identify the core attributes of the model and the PT interventions that can be provided within this tier system. In the second study, we did a SWOT analysis to understand the strength and the weaknesses of a collaborative tiered peer service delivery model, and also available opportunities to implement this model in current practice and the potential barriers that we can face when we want to implement this model in different countries. Today, I'm going to only present the results of our first study. As I said earlier, our aim was to identify the core attributes of a collaborative tiered school-based physiotherapy model and identification of the PT interventions. When we say core attributes, we mean the foundation of service delivery and service organizations. So we can think that these are the guiding principles for PT interventions. And when we say PT interventions for our study, we mean that actions performed by the therapist to deliver services. It may include assessment, strategies, PT programming, education, communication, accommodation, or equipment, anything about equipment delivery. It may target one student, a group of students, or all students, or parents, educators, school, or environment. To identify the core attributes and PT interventions, we use the Delphi method to consult the experts in school-based PT. When we initiated this study, we already had a network led by my supervisor, Chantal Camden. So it included experts, clinicians, and researchers from all over the world. So we sent an invitation to 38 members, and 24 of them from 9 countries participated in our studies. Before Delphi rounds, we also organized introductory webinars to introduce the model that we are proposing, and also we clarify our study objectives. After then, using RedCap software, we did 3 rounds of Delphi. In the first round of the Delphi, we asked our participants to generate ideas about core attributes and PT interventions. And in the second round, we asked our participants to rate the importance of the generated ideas using 11-point scale. In the final round, our participants re-rated the ideas that did not reach the adequate agreement in the previous round. So for a statement or an idea to reach an agreement, at least 80% of the participants should have scored 7 or more. So we end up with 41 core attributes, and we categorize them under 8 categories. Our first category was goals, mission, and scope of the practice. So under this category, our participants agreed that PTs should promote participation in school routine, peer interactions, and community involvement, and PTs also should advocate for school access and inclusive practice. PTs also should prepare students for transition, especially transition to school, post-secondary education, employment, and independent living in collaboration with school personnel and families. And also there was a consensus that the PTs should also concern about the general health of the students, and they should promote general health lifestyle for not only for students, but also school personnel and families. The next category was coaching and knowledge translation. And our participants agree that coaching was an important element for school-based physiotherapy. And PTs should coach school personnel and families for implementation of the strategies, differentiating instructions, and identifying changes in child performance. And they should also follow up regarding the strategies if they are implemented successfully. Also, our participants agreed that the PTs should also have some responsibilities to build the capacity of the educators and families, as well as the children, for identification of the students with atypical development, likelihood and consequences of the secondary health conditions, importance of well-functioning motor skills and physical activity, and role and expertise of physiotherapy profession. And there were also some key elements for the service delivery that our participants agreed upon, such as providing services aligned with curriculum goals, evidence-based teaching strategies, delivering interventions in context, and using general curriculum activities for assessment and strategies. But at the same time, PT should offer PT-based diagnosis and assessment, and all the PT activities should be documented. When it comes to PT approaches, our participants suggested that PTs should use a strength-based model of problem solving, and they should also adopt a learning center approach. Also, there were some statements about inclusive and accessible service delivery, such as providing safe and culturally sensitive practice for all students. For example, acknowledging the specific needs of Indigenous people. And providing services which are flexible and responsive to a range of school contexts, such as gym, playground, or library. And using language that's accessible when communicating with families. For example, respecting the parents' primary language, and then getting help from an interpreter if needed. In the next step, there were some statements about knowledge and professional development. And our participants had a consensus that PTs should understand the school culture, and they should have some knowledge about relevant laws and policies, and should be aware of the community level physical therapy opportunities, and they should take some responsibilities for continuing education and professional development, and they should be also knowledgeable about evidence-based interventions and implement them, and also train, they should have some role in training and mentoring new physiotherapists. Another important part of this model was also school providing, considering school-wide approaches and UDS strategies. So under this category, our participants suggested that PTs should adopt a school-wide approaches for initiatives and interventions to serve all students, and they should be committed to continuous improvement of continuous improvement of the outcomes, not only for students, but also for school personnel and throughout the school. And they should also support school team for environmental modification and educational, designing the educational activities considering UDS strategies. In the last category, we have partnership and teamwork. So we all know that for school-based PT, this is one of the important elements. And our participants agree that PTs should committed to interdisciplinary and multidisciplinary approaches, and they should identify common needs and goals and co-create intervention with families, the school personnel, and other service providers. And they should use a collaborative approach for communication and problem solving, and they should also respect for expertise of the school personnel. And PTs also should collaborate with healthcare professionals regarding students' medical issues, and they should also take some responsibilities being a conduit between health and education system. And also our participants agreed that PTs should be part of the school team and should have a role at the departmental policy and procedures. In the last statement was also about using a cross-agency service delivery process. Our participants also agree that PTs should use a cross-agency service delivery. So it means that agencies should work side by side and share their resources and capabilities to pursue the same goal, but they should also retain their independence. Even though this is a new and novel approach, I can see that in the school-based PT, PTs and OTs are more often sharing their resources and capabilities. When it comes to PT interventions, we identified 121 interventions for all tiers. So out of them, 37 were for tier 1, 24 for tier 2, 60 for tier 3. So our participants also agree that the tier 1 was the universal support for all students. If and when a child requires additional supports, she or he should be provided with tier 3, tier 2 services. And if a child requires comprehensive support, or if a child in a condition that requires comprehensive support, and that child should be provided with tier 3 interventions. So we also made it clear in our paper that a child can access different level of services in different time points based on their needs. For example, a child can be provided with tier 1 interventions in this week, but maybe next week they can be provided with comprehensive support and then tier 3 level of services considering their needs in that time point. So the tier interventions, some of that we identified through Delphi, some of them were general statement, such as developing environment that promote motor learning in context. However, some of them were specific, such as one-on-one training for students regarding balance strategies. So we had 121 PT interventions. We categorized them under 15 categories. So considering students' outcomes, such as increasing quality of life and health, increasing physical activity and physical fitness, improving equipment acquisition and utilization, and so on. So I'm not going to go details for each category. So I'm going to give some examples from some of them. For example, improving physical environment for learning. This was one of the category. And for tier 1 level, our participants agreed that creating a supportive school environment that encouraging physical activity was one of the tier interventions. So it can mean that adaptation in playground. So I'm going to share a video showing one examples from accessible playground.
Right, here we go.
So this saving allow all children, including children with disabilities, to get in and have fun. So for tier 2 level, our participants also suggested modifications in the classroom and bathroom. For example, providing automated paper towel dispenser in a low level for the children with muscular dystrophy using a wheelchair because they cannot reach up high. So this kind of a modification can be done in the bathroom. And for the tier 3 level, our participants also agreed that PTs should support environmental changes to facilitate mobility in the playground. So for this one, actually, when we think about tier 3 is for the children with disabilities generally. So most of the children with severe disabilities, they are using a walker with small wheels. So they cannot really go outside with it. So providing, for example, a flat and then soft and a flat surfaces outside may give them some opportunity to also be mobilized in the playground area of the schools and maybe outside backyard of schools. So another examples for the physical activity and physical fitness. So for the tier 1 level, one of the example was collaboration with school team for school-wide movement activities. So I'm going to show an example from China. So here you can see that all students, including teachers and then the principals, they are all dancing all together. So for the tier 2 level, our participants give an example as serving as a coach and consultant to support for appropriate playground activities. And for tier 3 level, providing the performance-related physical fitness training, for example, for the children with developmental coordination disorders. Some of the PT interventions they provided and was agreed upon were applicable for all tiers, such as preparing e-learning materials for school personnel. So then we put them under all tiers. So these are some of the examples from the interventions. So as summary, so our overarching goal of this model was to improve students' participation, school access, engagement, health and healthy lifestyle, and transition to higher education using collaboration and using the 4 elements of collaboration, especially such as teamwork, coaching, knowledge translation, and partnership. And these models grounded into 2 principles. So the service should be aligned with the curriculum goals and activities, and it should be inclusive and accessible. And we choose tiered approach to provide services for all students. So these services can be at the level of the student, school, family, and community. So this is kind of a summary of our project. And I'm happy to answer your questions at the end of our presentations. And thank you for listening.
Thank you very much, Eda. We might just move straight through into the presentation by Kirstin Macdonald, who's going to share some of the findings of her PhD series of studies.
All right, thank you, Nikki. I'll just bear with me while I share my screen. Okay, just confirming you can see that.
Yep,
Yes,
that looks good.
Wonderful. All right, so hi everyone. My name is Kirstin Macdonald and I currently work with the physiotherapy program at Bond University on the Gold Coast in Australia. I've been a registered physiotherapist for 18 years and a school-based physiotherapy researcher over the last 9 years. So I've been asked to present today the findings from my PhD that are most relevant to school-based physiotherapists. So Nikki mentioned earlier the different activities that the IOPT school-based physiotherapy subgroup have been involved in over the last few years. And I've been fortunate enough to be involved in these various activities undertaken by the group since our meeting at the DScPT conference in Geneva in 2019. So to provide further context as to how the findings of my PhD are relevant to school-based physios, my research provides support for some of the proposed physiotherapy interventions listed under Tier 1 of the model that Eda's just presented, specifically relating to health and physical activity promotion. So there are 3 main aims I've developed for today's presentation, which are based on the objectives of my PhD. So firstly, to summarise more generally the literature regarding the link between physical activity and learning, and then more specifically the relationship between motor proficiency and academic outcomes in school-aged children. I've placed in parentheses the sections within my thesis that are relevant to these aims. Now, secondly, to explore how motor skill programs may be utilised as a strategy to promote children's motor proficiency and academic outcomes, specifically with children in the early years of primary school was the focus of my PhD. And finally, I'll summarise the implications of the findings from my PhD for school-based physiotherapists, specifically relating to health and physical activity promotion. Now, as physiotherapists, we are strong advocates for the importance of physical activity and its benefits for children's physical, cognitive and mental health. And the most recent physical activity and sedentary behaviour guidelines published by WHO in 2020 continue to recommend that children and young people undertake at least 60 minutes a day of moderate to vigorous physical activity, as well as exercises to strengthen muscle and bone on at least 3 days a week. And these guidelines are consistent with children and adolescents living with a disability. However, in 2022, the Active Healthy Kids Global Alliance published findings from the most recent surveillance of children and young people's physical activity from around the globe. So it included results from 57 participating countries and highlighting that physical inactivity continues to remain a global public health concern, with only a quarter to a third meeting current recommendations. In Australia, where I conducted the studies included in my PhD, current trends suggest that overall, Australian children are demonstrating low levels of physical activity, aerobic and muscular fitness, as well as motor skill proficiency. Now, as physios, we understand the importance of motor skill development for children's overall development. In fact, it's critical for promoting other areas of development. Several conceptual models have been proposed to explain how motor skill proficiency may be related to lifelong engagement in physical activity. For example, the one depicted here, published by Holteen and colleagues in 2018. However, what does the literature say regarding the link between motor skill proficiency and health-related outcomes? So based on a number of systematic reviews, there appears to be a strong level of evidence that children's motor skill proficiency is positively associated with health-related outcomes, including cardiorespiratory fitness, weight status, and participation in physical activity. As we know, healthy habits start early and children spend a considerable amount of time at school. Thus, schools are in an ideal position to positively influence children's physical activity behaviour. In fact, WHO and UNESCO support this notion and recommend that every school should be a health-promoting school. However, it is essential that strategies to promote children's physical development do not adversely impact educational outcomes. So in order to advocate to schools and educators for the importance of providing students with opportunities to move and be active during the school day, a rapidly expanding body of research has examined relationships between physical activity, cognition, and academic performance in children and adolescents. So several conceptual models examining this link hypothesize that physical activity may firstly modify children's cognition, and it's these improvements in cognitive function that may underlie improvements in academic performance. Notably, motor proficiency has yet to be included in these conceptual models. So results from a narrative review of the literature that I conducted as part of my PhD, involving 7 key systematic reviews conducted over nearly 2 decades, revealed in relation to observational studies, so that includes both cross-sectional and longitudinal studies, positive relationships between physical activity, physical fitness, cognition, and academic performance are consistently reported. However, in relation to experimental studies, which test whether this is a cause and effect relationship, there appears to be currently inconclusive evidence to support a beneficial effect of physical activity interventions on cognition and overall academic performance. However, there's promising evidence to support a beneficial effect on children's mathematical outcomes. And interestingly, cognitively engaging types of physical activity interventions, such as those involving complex motor skills, may be more beneficial than aerobic physical activity interventions. And finally, it's important to note that considerable variability exists across studies in relation to study design, physical activity interventions, comparison groups, and outcome measures, which led to there being inconclusive evidence. So returning to the school setting, a key priority reported by physical activity researchers and leaders across the globe is to encourage schools to adopt a whole school approach to physical activity promotion, as outlined in the diagram you can see on the slide. So one of these recommendations is for schools to provide students with 150 minutes of organised physical activity during school class time each week, which could be delivered during either physical education, but also more generally during the school day. And one of the strategies for encouraging children to be more active during the school day that may also improve learning is classroom-based physical activity. Now, classroom-based physical activity transforms sedentary classrooms into active ones and involves either incorporating movement into academic lessons or scheduling physical activity breaks during regular class time with or without an academic focus. So the evidence to date, again, based on several systematic reviews, has been promising, with positive outcomes found for both physical activity and learning outcomes, including increases in children's physical activity levels, improved academic performance, and improved concentration in the classroom. However, again, findings should be also be interpreted with caution due to limitations in the methodological quality of some studies. So following this narrative review of the literature, it was apparent that no systematic reviews had identified that it had examined relationships between motor proficiency and specific outcomes in school-aged children and adolescents, even though both motor proficiency and the components of health-related physical fitness are considered core aspects of children's physical development. So therefore, I conducted a systematic review which aimed to identify, critically appraise and synthesize findings of studies examining relationships between motor proficiency and academic performance in maths and reading in typically developing school-aged children and adolescents. So a systematic search of the literature was conducted in accordance with the PRISMA guidelines, and a total of 55 studies were eligible for inclusion in the review. So 51 observational and only 4 experimental studies. So this table summarises the overall levels of evidence from studies examining associations between fine and gross motor proficiency and mathematics outcomes. So there were positive associations between all components of fine motor proficiency and maths, with a strong level of evidence for fine motor integration and total fine motor scores. There was a strong level of evidence to support associations between mathematics and speed and agility and total gross motor scores, despite some inconsistencies in the literature. A similar trend was observed for relationships between motor proficiency and reading outcomes. However, more inconsistencies were evident. So overall, there was a strong level of evidence to support a positive relationship between reading and fine motor integration and total fine motor scores. And there was a strong level of evidence to support a significant relationship between reading and upper limb coordination and total gross motor scores. So it's important to note that overall, there appeared to be insufficient or inconsistent evidence to support relationships between academic outcomes and several components of gross motor proficiency. So only 4 experimental studies were eligible for inclusion in the review. The 2 studies that examined the impact of gross motor skill interventions on reading outcomes found the intervention group significantly improved compared to the control group. And the 2 studies that examined the impact of motor skill interventions on maths outcomes found that participants in intervention groups significantly improved their maths outcomes compared to the control group in 2 out of the 3 studies. And I won't go into detail, but for your information, I've also summarised the intervention parameters of the 4 studies included in the review. So in conclusion, overall findings from the observational studies suggest that significant positive relationships exist between academic performance in maths and reading and fine motor proficiency, specifically fine motor integration and total fine motor scores, and also gross motor proficiency, specifically upper limb coordination, speed and agility, and total gross motor scores. In relation to findings from experimental studies, school-based motor skill interventions may be beneficial for children's mathematical and reading skills. However, further research is required to verify these findings. So the systematic review revealed inconsistent or insufficient findings regarding the relationships between several specific components of gross motor proficiency and academic performance in maths and reading. So therefore, a more comprehensive understanding of how the different components of gross motor proficiency are related to maths and reading was deemed necessary. So therefore, the aim of my first study was to examine associations between fine and gross motor proficiency and academic performance in mathematics and reading, specifically with Year 1 school children. Now, I conducted this study while coordinating a Healthy Schools project in Australia, which involved university health science students completing their clinical placement within the school setting. So students were involved in delivering interventions across the 3 different tiers previously identified in a collaborative tiered service delivery model. Now, this particular study involved analysing baseline data prior to implementing a 12-week classroom-based gross motor program with Year 1 children, which was a Tier 1 intervention implemented as part of the Tweed Healthy Schools project. So this cross-sectional study involved a total of 55 children from 3 Year 1 classes from 2 primary schools in northern New South Wales, Australia. Children's motor proficiency was assessed using the Brunink's-Ozoretsky test of motor proficiency, and academic performance in maths and reading was assessed using the Wechsler Individual Achievement Test of the Australian version. So in relation to the results, this table shows the correlations between the motor composite scores of the BOT2 and maths and reading. So a significant moderate correlation was evident between total motor proficiency and mathematical skills. And consistent with findings from the systematic review, significant moderate correlations were found between fine motor skills and maths and the majority of reading outcomes. Now, in relation to the different components of fine and gross motor proficiency, significant moderate positive correlations were evident between fine motor integration and reading and maths outcomes. And fine motor precision and manual dexterity were also related to the maths reasoning subtests. However, no significant relationships were reported between the subtests of gross motor proficiency and academic outcomes. We ran one final set of analyses to determine whether any components of motor proficiency were predictive of maths and reading performance. As can be seen here, the final model demonstrates that fine motor integration was a significant predictor of both maths and reading performance. So in conclusion, from study 1, total motor proficiency was related to children's mathematical skills, and fine motor integration skills were predictive of maths and reading skills. And the implications from this study suggest that a role may exist for physiotherapists to assist educators to identify early for further investigation any child with poorly developed or delayed motor skills, as it may impact their academic performance. So moving on to the second study, prior to designing a school-based motor skill intervention, with children in the early years of primary school in Australia, it was essential to gain insight into existing practices regarding the frequency, type, and context of physical activity opportunities being provided to students in the early years of primary school during the school day. Thus, the aim of my next study was to directly observe Year 1 children's physical activity and its context during school class time and identify opportunities to incorporate additional activity. So this study was cross-sectional in design and conducted in one primary school in southeast Queensland in Australia. A total of 34 children from 4 Year 1 classes were included in the study. Now, direct observation is a valid and reliable method used to observe and record the intensity and type of children's physical activity, as well as the physical and social context in which the activity occurs. So the direct observation tool we chose was the observation system for recording physical activity in children in the elementary setting. However, we modified it slightly in order to contextualise the tool for Australian primary school settings. So physical activity was observed and recorded for 7 different observation categories. And for each class, data was collected over the period of a week using the following observation protocol. So a total of 5,305 observation intervals were recorded, which is equivalent to approximately 44 hours over the 4 weeks. So the following graph summarises the intensity levels of children's physical activity observed during school class time. So overall, you can see that Year 1 children were sedentary for the majority, equivalent to 86% of observation intervals recorded during school class time. This graph summarises the intensity levels of children's physical activity during academic lessons, classroom-based physical activity, and PE or school sport. Firstly, it's important to note that 82% of the observation intervals were recorded during academic lessons, and this was in contrast to only 2.8% of intervals recorded for classroom-based physical activity and 5.9% recorded for PE and school sport. So as expected, children undertook more light and moderate to vigorous physical activity during PE lessons and school sport compared to academic lessons. However, notably around 62% of PE lessons involved activities that were classified as sedentary. To summarise where additional activity could be incorporated during school class time, given that classroom-based physical activity and children's incidental physical activity were not observed very often, it would be fantastic to see teachers provide students with structured activities such as active lessons and breaks, as well as unstructured opportunities by promoting incidental activity in the classroom. So in conclusion, Year 1 children were observed to be predominantly sedentary during school class time, undertaking limited amounts of light and moderate to vigorous physical activity. Opportunities to incorporate additional physical activity during class time include implementing movement into academic lessons or during transitions between lessons, as well as encouraging children's incidental physical activity. And the implications from this study suggest that educators need to be trained and supported to provide structured and unstructured movement opportunities to children during school class time. So in study 2, classroom-based physical activity, particularly physically active lessons, was seldom observed being utilised by classroom teachers with Year 1 children. Thus, it was recommended as a potential method that teachers could employ to increase children's activity levels. So therefore, the aim of study 3 was to examine factors that influence the provision of classroom-based physical activity to students in the early years of primary school in Australia within a social ecological framework. So a 45-item online questionnaire was administered to Australian classroom teachers and assistant, deputy and school principals working with students in prep kindergarten to Year 2. Now, the survey response rate was 22%, with data analysed from only 34 respondents. So several themes emerged. So the organisational level factors that were most commonly reported as barriers included insufficient time in the curriculum, lack of training, resources and equipment available to deliver classroom-based physical activity, and a lack of space within the classroom. Individual factors relating to teacher attitudes, knowledge and beliefs and perceived competency were also identified as major barriers. However, several solutions were proposed by both teachers and school principals, including creating a school culture that is supportive towards physical activity and valued by school administrators, and the provision of training, resources and equipment relating to classroom-based physical activity. So in conclusion, barriers to providing classroom physical activity to students in the early years of primary school in Australia include insufficient time, training opportunities, resources and educator attitudes and confidence. Proposed solutions include the provision of training and resources to educators, including education regarding the benefits of classroom-based physical activity. So the implications of this study suggest that multiple strategies need to be employed at both the educator and school level to overcome existing barriers to providing classroom-based physical activity programs to students, specifically in the early years of primary school in Australia. Now, the systematic review we conducted identified that a limited number of studies had evaluated the impact of classroom-based physical activity interventions, particularly motor skill interventions, on children's motor proficiency and academic outcomes. So findings from studies 2 and 3 sought to explore whether early primary school classrooms in Australia could be feasible settings to implement physical activity opportunities during class time, and revealed that classroom-based physical activity may be a method that educators could potentially utilise to increase children's movement opportunities. So therefore, the aim of study 4 was to explore whether Year 1 school children exposed to a 12-week classroom-based gross motor program progress differently to Year 1 children undertaking their regular school program in motor proficiency, mathematics and reading outcomes. So this study was exploratory in nature, in which outcomes associated with exposure or non-exposure to a 12-week classroom-based gross motor program delivered as part of the Tweed Healthy Schools project was evaluated in the form of a pilot study. So as part of the Tweed Healthy Schools project, in addition to their regular Year 1 school program, children in both the reading and maths classes engaged in a gross motor circuit 4 days a week prior to the commencement of academic lessons. The reading class then had gross motor activities integrated into their reading lessons 4 days a week, and the maths class had activities integrated into their maths lessons 3 days a week. The gross motor circuits and physically active classes were delivered by myself, a physiotherapist, along with physiotherapy and exercise science students. And the normal Year 1 class at the comparison school was not exposed to the 12-week classroom-based physical activity program. So in relation to the results, so no significant differences between classes were found at baseline for mathematics, reading and motor proficiency outcomes. Now this graph depicts the mean change in mathematics scores for each class in red, along with the corresponding confidence intervals. So as evident in the following graph, children in both the reading and maths classes demonstrated significantly greater mean change scores for maths composite scores than children in the normal class. In relation to the reading composite scores, only children in the maths class demonstrated significantly greater mean change scores for reading composite scores than children in the normal class. And finally, in relation to total motor proficiency scores, only children in the maths class demonstrated significantly greater mean change scores for total motor proficiency than children in the normal class. So in conclusion, participation in a 12-week classroom-based gross motor program was associated with improvements in Year 1 children's motor proficiency and academic outcomes, particularly their mathematical skills. So the implications from this study is that findings will usefully inform and justify the benefits of a larger, more robust experimental study in this field in the future. Now, it's important to acknowledge several limitations across the 5 studies included in my PhD, including that a limited number of high-quality experimental studies were eligible for inclusion in the systematic review, with only 4 being eligible. And it's important to acknowledge that small sample sizes were evident in each of the studies, and this may limit the generalisability of the study findings. And finally, the pilot study that I just presented as part of study 4 was exploratory in nature, and thus it wasn't possible to infer whether differences observed between the 3 Year 1 classes in academic performance and motor proficiency were solely due to the 12-week classroom-based gross motor program. All right, so having presented the results of my studies, finally I would like to discuss the implications of this research to school-based physios by referring to the collaborative tiered school-based physiotherapy service delivery model that Eda has just presented. So the 3 core attributes of a school-based physio my research best aligns with includes core attribute 1, so promoting general health and healthy lifestyles for students, school personnel and families. Core attribute 6, specifically building the capacity of school personnel and families regarding the importance of well-functioning motor skills and physical activity. And core attribute 7, adopting a school-wide approach for initiatives and interventions relating to health and physical activity promotion that all students and all classes will benefit from. In relation to the 37 Tier 1 intervention, my research aligns with early identification of students, particularly with poorly developed or delayed motor skills, supporting school-wide physical activity initiatives with a focus on classroom-based gross motor programs, building capacity of staff, students and families regarding health and physical activity promotion, and supporting schools to develop a positive culture towards health and physical activity promotion through the implementation of school policies. So in summary, implications from my research suggest there may be an evolving health promotion role for physiotherapists working within the school setting that may include training educators to facilitate earlier identification of children with poorly developed or delayed motor skills. And this may include an initial period of observation by physios within the school setting, whether or not it be during lunchtime or breaks, or it could actually be observing PE lessons to be able to make that identification. Secondly, assisting educators with the design, implementation and evaluation of age-appropriate motor skill programs. And just to note, not all, particularly in Australia, and I understand across the globe as well, not all schools will employ specialised PE teachers, and so it's the responsibility of the classroom teacher to carry out the PE curriculum. And so where there are specialised physical education teachers, definitely consulting with them in this process would be important. And thirdly, the provision of training and resources to educators and school staff to support children's overall health and wellbeing. And to unpack that a little bit further, strategies for capacity building may include increasing knowledge and awareness of the benefits of physical activity on children's mental, physical, social, emotional and academic outcomes, providing support and training to improve educator competence and confidence to deliver physical activity initiatives, identifying and implementing opportunities for children to be active during the school day, and reviewing strategies, policies and practices currently in place regarding the use of a health promoting schools framework and comprehensive school physical activity program. All right, so Nikki mentioned before that there will be a couple of questions in the polls. So I guess moving on from and looking ahead, following my PhD, some of the information that I'm interested in finding out is actually how many school-based physiotherapists are currently implementing Tier 1 interventions. And for those who aren't or are, understanding the barriers and facilitators to actually implementing some of these Tier 1 interventions. All right, that brings me to the end of my presentation. And again, I'll certainly happy to answer questions at the end.
Thank you very much, Kirsty. Great presentations from both Kirsty and Eda there that I'm sure are stimulating lots of thoughts about what could go on in the future in school-based physiotherapy. We're now going to have Connie present to us the work of the school-based physiotherapy working group with developing their fact sheet. So I'll hand over to Connie.
Thank you so much. This fact sheet was developed by the IOPTP work group to describe physical therapy physiotherapy services in public schools. Pardon me, I'm from the US, so I'm thinking physical therapy. And this document can be used for you to advocate for physical therapy services and supports that you can provide in schools. We consider ourselves to be movement experts, and we have skills in a multitude of areas that can support the health and well-being of very young children right through teenagers and young adults. Our primary roles really are to support access to the educational environment. And that's a place where a lot of us have been focusing a lot of our efforts. So that might mean making sure that children have access to the equipment that they need, to walk, a gait trainer or something so that they can walk from place to place. Prevention of impairments that might include use of standing equipment so that a child can maintain their bone mineral density. And then I would call the discussion around Tier 1 as promoting that health and well-being of students. And the Tier 1 interventions are really the place where we can have the most impact, because we can work with a large number of students and work at that school level to promote health and well-being of all the students. We know that physical activity is vital for children's physical and mental health and well-being. And Kirstin has shared with us that it's also really important potentially for their learning. When we implement health promotion activities, we can prevent obesity, non-communicable disease, chronic health conditions, and we know that it supports the mental health, cognitive function, and academic performance of all the students. Many of us do already work to identify children who have health conditions and impairments that impact their ability to access their educational environment. And that can include negotiating a playground, participating in physical education classes, or walking the campus of the actual school. Another primary role for us is to make sure that all students are included in all aspects of life. We do spend an awful lot of time coaching to this and educating staff about ways that they can include students when that's not something that they may be doing. We might also be providing equipment, information, and additional resources that would help support inclusion of those students. We are also there to support independence of students in physical care routines. And some students have quite complex disabilities. They might have a number of medical diagnoses and require use of mechanical lifting equipment in order to move from wheelchair to chair to a changing table to have their personal care needs met. We might be training staff to help someone transfer either from a wheelchair to the floor, from the floor back to the wheelchair, from a chair to a chair. And we might also be supporting equipment needs. We might be prescribing walkers, gait trainers, standers in order to ensure that children have the equipment that they need to participate in school. We are also really important members of the school teams, and I work in a large suburban school district in the US, and we have physical therapists that are assigned to every single school within our area. And it's our role to make sure that children can access all of their educational opportunities. We participate in meetings regarding students and the nature of their disability, IEP meetings with teachers, school staff, families, and that's one of our a very important role that we have. We also use a variety of collaborative practices and tiered interventions in order to support those needs. Historically, we did all of that Tier 3 intervention, that one-to-one, where I would just go and work with that individual student. And over time, we've now been doing much more Tier 2 interventions where we might be working with small groups of students. And many of us are trying to expand into that Tier 1 where we're supporting the entire school. You might hear the term workload versus caseload. And so caseload, that's working with all of the students that you're technically assigned to. If you have a workload approach, then you're looking at working with all of the students within your school. And it's really a mindset that you're going to do that. You'd be surprised how, we've been presented tonight with a whole way to think about those kinds of interventions and the different things that we might do. But if you're working within a workload capacity, you'd be surprised how one small thing that you could do could have such a huge impact on so many students. And I'm really grateful for the work of Eda and Kirstin to help us identify what those things are and what they look like, because that's always the hardest part, right? You can look and see a slide and see a model, and it might help you to think, but it's this work that's really foundational for the future for all of us. There are some links to some additional resources, the IOPTP website, of course, and then the American Physical Therapy Association Academy of Pediatric Physical Therapy does have a fact sheet on school-based therapy, and there's additional fact sheets as well. This document that you're looking at right now will be up on the IOPTP website at the end of May, and there is an English version, a French version, and a Spanish version, so that hopefully that will help to make things a little bit more accessible. Thank you.
Thanks so much, Connie. So the last few things that we have now to go through before we get into some discussion and open the floor for questions is just to run through some polls that are of particular interest to our speakers and will help form more strategic activities by the school-based working group. So I will go ahead and share my screen. If you can, for those of you who were able to do it, get your apps ready for Poll Everywhere. Let me just pop up the poll. Okay, Kirsty or Cherie, can you just give me an indication of whether that's come up?
Yep, we can see it.
That's okay. I'm going to pop that onto presentation now. Is it still there?
Yep, we can see it.
Okay, so if you want to go ahead and respond to the poll now. So for those working as school-based physiotherapists, are you implementing Tier 1 interventions relating to health and physical activity promotion in your current role? I see a total of 12 results, but I need to pop onto there, sorry. Okay, so for those who have responded, so we now have 22, a few more still responding. Getting closer up to the 3/4 mark are actually providing Tier 1 interventions, which is wonderful to see that happening. And I think only sort of 5 years ago, there was really strong resistance within the community of schools to physiotherapists moving into those Tier 1 areas. There's a bit of a scare factor about that taking up all your time over more direct interventions with one-on-one students in the schools. Okay. Thank you for that. We're going to take copies of these results. So we'll share them all when we're able to post the information. We'll share them all with you. I'll just exit out of that poll. We'll just jump into our second poll. Kirsty, can you please confirm that you're still seeing the second poll?
Yes. Yeah, it's coming. Yep.
So our second question is, what are the biggest barriers to implementing Tier 1 interventions in current school-based physiotherapist roles? Time, models, staffing. So out of So you can see the big thing there is time and perhaps the school's models and frameworks. We saw in the scoping review that the laws and the acts that were in place in different countries also potentially impacted the way Tier 1 models could be implemented, because the focus for funding was directed at children with diagnosed conditions presenting with disability. Great, thank you very much. So again, we'll share these results. And then our final poll that we would like to share. I can get out of this one. Again, Kirsty, if you can just confirm that this is coming up.
Yes.
Right. Okay. So poll 3, is there anything the IOP can do to support school-based physiotherapy service provision internationally? So without biasing, you know, your responses, you know, is there specific research that you think is needed? Is there very specific advocacy that's needed? Are there regions of the world that we should be focusing on to support more? Is there more information that you're needing in order to be able to advocate yourself at a local level? So this will result in a series of responses. You'll see them popping up on the screen in front of you, but we'll also gather all of this information together and be able to share that. And we will share that specifically with the school-based physiotherapy working group, who will use that to help with their strategic activities. And they may also talk to specific subgroups of the IOP, like the research group or the practice group, to look at how they can carry over some of these needs and actually start implementing some activities that will be helpful for the school-based physiotherapy community. Wonderful. So I'm seeing this poll start to slow up now. No more responses coming in for now. I can leave that open though for a little bit for anybody who wishes to continue with that one. And in the meantime, I will share, go back to sharing my slides. So stop that share. Kirsty, can you just confirm that I'm back on the slides?
Yes, you are.
Thank you. Okay, so to summarise the information that we've gathered today, firstly, we want to highlight that the IOP is there to support physiotherapy practices in schools, and we will do what we can to support members, physiotherapists from IOP member countries. There is also the IOP fact sheet, which Connie went through with you and explained to you how that was developed and how you might be able to use that. There is evidence to support physiotherapy services in schools, but we could do with more. So if anybody's looking to do research in the future in this space, then please go ahead and get in contact with the physiotherapy, school-based physiotherapy working group. And you may be able to reach out specifically to the speakers today to help guide future research studies that are really needed in this space. And also just to express that there is a framework to guide clinicians, researchers and policymakers regarding the implementation of tiered therapy services in schools, which Eda spoke about today across the different tiers, and also Kirsty elaborated a little bit on the Treat Healthy Schools framework, which also presented some of those tiered models of services. And hopefully the information can help with including preventative health promotion services for children in the school environments, in addition to the direct interventions and assessments that we may do with children diagnosed with specific conditions. We've been through those 3 polls. And again, just to highlight the information about research, if you would like to continue to write things in the poll, if you think there's focused research needed or you're interested in it, please pop that in the poll and we'll share that back with the school-based group who may be able to get in contact with you. So I wanted to say a massive thank you for everybody who's attended today for the 5th International IOP webinar on school-based physiotherapy, and specifically to thank Eda, Kirstin and Connie for their time and input. I know it's not always the best time of day for our international speakers to join us for presenting, but we really appreciate your time and your input. For anybody wanting to contact or to have a closer look at the IOP website, there's the web page there, and the QR code will take you directly to the IOP website as well. Just be mindful that there is an IOP, like a bit of a skeleton web page that World Physiotherapy discuss the subgroup, the pediatric subgroup, but there is a specific page according to this link here that has all the resources you might be after. Again, for anybody who missed the attendance certificates link at the beginning, please, if you are in attendance and you would like an attendance certificate, please go ahead and scan this QR code and just list your name and your email and your country that you're coming in from, and we'll be able to supply you with an attendance certificate. I'll just hold there for one moment for anyone who's wishing to scan it. A few key references. These will be put up on the IOP website once you are able to access this a little bit later in the year. And that's all of the information that I have to share with you now. So I'm going to pause and come back to each of our speakers if you are all able to have your cameras and mics ready to turn on as needed. So please feel free to fire away in the chat if you have questions and you don't want to pop your cameras on directly and talk. And Cherie is going to pick up the questions in the chat and she'll represent those for you. But for anybody who would like to speak directly, please go ahead and do that. We really welcome you to do it. So we'll just sit quietly and wait for questions to come in at this point. Thank you.
Nikki, this is Barb Conley.
Hi, Barb.
Hello. Just while you're waiting for questions to come in, just to let the participants know that there's also materials posted on the IOPTP website from the first 4 webinars that we did present this year, and that they can go to that website and either get materials or recordings.
Great, thank you. Please don't be shy. If you have questions, feel free to pop them in the chat or pop your camera and mic on and ask either Kirsty or Connie or Eda or myself any questions you might have.
I have a question.
Hi,
My name is, hi, how are you? My name is Sue. I'm from the United States. And I was curious as to what kind of education your teachers get maybe in Australia or some of the other countries that would support being supportive of tier 1 interventions and implementing them with some level of fidelity, you know, with the guidance of a physical therapist, even an occupational therapist. I don't know if that question makes sense or not, but I know often in the US, we find that teachers really have no background when they come in to physical education, the value that physical activity provides for students. They're so busy putting checks in all the boxes for the curriculum and for this and for that, it becomes very difficult. And we often question what kinds of things are they learning? You know, the ones that go to college to become educators. And is there a move to sort of embed some of this or have the opportunity to embed some of this information, you know, into curriculum often we're speaking to the choir when you have all physical therapists or physiotherapists on. We all agree that these are things that are important, but the people who have to implement them, because there's just not enough of us, sometimes don't get that information. And so my question is advocacy at some level, but I'd be curious as to other countries if teachers do get some sort of background in education and the value of physical education and physical literacy in that area. Thank you. Sorry.
No, great question. Thank you. Kirsty, would you like to answer this or would you like me to cover it?
Well, I was going to say, if you want to, did you want to start off and then I'll add in? Yeah.
Okay.
I can imagine that I can anticipate that you have a couple of thoughts on that.
So here in Australia, I can answer this from experience. So having gone through some education degrees myself here, we're focused on early childhood and primary education studies. We in Australia don't have a mandate to have information like that embedded into the curriculum for primary education teachers or high school education teachers, even in the early childhood years of training in terms of their entry level education into teaching. However, there's a strong encouragement for them to undertake postgraduate education, and not many do. I don't know what the statistics are, but they're not required to get more money, and it doesn't help them get more money, so many don't do it. And so really it comes down to the physiotherapist having very good relationships with the teachers that they're working with, and trying to work alongside them and collaboratively to establish activities in the school that will be focused on tier 1 models. So it's definitely a challenge, and Kirsty can probably talk more to this in terms of the work that she's just presented to you was embedded from a Treat Healthy Schools program that we set up, where Kirsty was supervising all of the health professionals coming into schools and running programs through the student-led activities. And part of that process, we evaluated feedback from the teachers to see what they thought about that. Did it get in their road or were they happy with it? And I know Kirsty's quite aware of that, so I might hand over to Kirsty and she can share a little bit more about that with you.
Yeah, thank you. It's a really, really good question. And I think that's sort of, it kind of stimulates future research, because I think the biggest thing at the moment that I'm hearing is, can you provide, we want to see the evidence. And off the back of, I guess, my experience working with the Treat Healthy Schools project, as well as my PhD, that seems to be, particularly the survey that I conducted with the classroom teachers, they're keen to find that they want resources, they want to hear about what the benefits are. And so that's where it's now looking forwards to either, okay, do we need to start evaluating some workshops that we do and present to the teachers and get feedback that way. I know, Eda, off the back of the research that you've done with the Delphi studies, the next step in that process is certainly looking at conducting some experimental studies to look at the feasibility of conducting some of these interventions. So that's definitely, I believe we do need to start doing that. But in the meantime, for those of you who are in a position within your schools to talk to your school leaders, and that they're supportive of this, I guess, tier 1 interventions of this type of approach, my first step would be, I guess, like anything, a bit of a needs assessment, find out what's currently being done, at a class level or at a whole sort of school level, find out, is there a need there? Is it actually happening there? And then the next step would be finding out again, even just the questions that I've asked you guys, what are the barriers and facilitators for doing that? And then a lot of the time the answer is going to be, we want training. And so it's that professional development training to be able to do that. And so that's the exciting part about, I think, this forum, is that we can start to look ahead and prioritise some of, I guess, not only research that we can do, but start to sort of break away at the, work away at the advocacy side of things, and what we can put in place sooner rather than later, as we know that research to practice does take time, but what we can do in the meantime. So really appreciate the question. I hope I answered it in some way.
Thank you, Kirsty. I know we've hit the end of our time period for the webinar today, but each of our speakers have agreed to stay on for anybody who wishes to stay on and ask some further questions. So please go ahead and continue to ask any questions that you have to make sure you're getting what you need out of the webinar today.
We do have one question in the chat where Connie's provided a response from a US perspective, but Paulina has asked, do you find that you need to provide a lot of documentation to the school to prove that you are registered, trained in mandatory reporting and working with children checks? So just wondering if you wanted to give perspectives from Australia and Canada.
Yes, certainly in Australia, we have the same requirements, which I think is a fair requirement. In fact, I think the physiotherapists are required to provide more documentation regarding safe work with children than our teachers are in the school environment. And perhaps that's more to do with the fact that we do more one-on-one and may at times isolate children, although that's not the kind of practice that we want to see going on, but we know it still does happen sometimes. Eda, do you want to comment on that as well from a Canadian perspective?
Yeah, sure. So when it comes to it really depends on the province in Canada. Right now I'm in Ontario, so here we don't really have to prove some certificates to we don't have all those requirements. But when it comes to Quebec, where I lived before, so where the Sherbrooke University was, so yes, we have to prove, and then we have to show that we are still continually searching for to develop ourselves, and then looking for professional development courses. So this is what they were requiring. So I think it depends on the provinces. I also would like to answer the previous questions actually from my experience working with the PEs here in Canada. I found that especially when I'm working in high schools, they are really they are aware of the importance of the health promotions. They know about how the physical activity is important, but when it comes to skill-related physical activity, so they don't know how to really train the kids in that sense. So, and also we really work side by side with the PE teachers in school settings. I'm really very satisfied how we are collaborating and how they are also valuing our knowledge, and also how we are sharing the information. This generally happens in high schools, as I told you, but when it comes to primary schools, yes, there is I don't know, but there is kind of very discrepancies between the putting the importance on physical educations. I can see that in the high schools there is a more emphasis. When it comes to primary schools, it is not really that much. So I think it depends on also the age level.
Yeah, Eda, I think that's a very good point. I happen to be married to a PE teacher in the primary school, and we have a lot of conversations about why don't you do more physical activity with the kids in the schools. And he says his mandate as a PE teacher in Queensland, Australia, is that he is to teach them and to ensure they develop fundamental motor skills that will give them opportunities to be physically active, but not to actually do physical activity with them. So that's in our local state here in Queensland. And I know it's different even from state to state in our own country here. Yeah, there is certainly a strong resistance to do more than develop the fundamental motor skills required, or sport-specific motor skills required for children to be active. I think we have some new questions.
I think just Connie kind of reiterating information about the US and some nice conversations happening amongst people in the chat.
Yeah, I was supporting what you said, Nikki, about PE teachers being very focused on curriculum and games and less on fitness, which I find extraordinarily frustrating, because if kids don't have foundational fitness, it impacts their health, and it definitely impacts their functional skills, which is going to impact them more in terms of their long-term life.
Yeah, couldn't agree more.
I have another question, and Connie brought this up earlier, and she talked about workload. And so caseload and workload is sort of a hot topic here in the US, because we're trying to move towards a workload model, but it really is a district, state, culture, administrative understanding, and it's, a complex kind of issue. So again, asking those who are on the call from a variety of countries, are your systems embracing this idea of workload where it's respectful of the value you bring across the board, or are people still really tied to this, whatever students are assigned to you is kind of what you do? I'm just kind of curious that way, because again, if we're moving more towards these tiered one, you've got to have staffing models that support that. And lots of times caseload models don't, because it doesn't give you that the flexibility of time to implement things at that level. So I'm curious as to what's going on in other places myself.
Maybe I can give. Oh, okay.
Sorry, you go. You go.
Okay, so maybe I can talk about Canada. So I know it depends. So in different provinces, it's different. But in Alberta, for example, they started implementing tiered approach, and especially for occupational therapies. And then the PTs are also getting into that track. So, and then PTs are right now part of school team in Alberta. But right now I'm in Ontario. So in Ontario, no, we are still in the caseload model. So, and I don't see any kind of light that we are going to workload models, and still we are trying to emphasize the importance of it, but it's so much on depending on the case, like the child. So the one of the, I think, drawback of it is what I see in my working experience. So because we do so many things, but you need to count on the child's from child sessions. So most of the time that you are spending at schools for a baby, you also want to do so many environmental changes, and everything all times is taken from one child's sessions. So I really see the drawbacks of it, but I don't see any changing in Ontario right now.
Sherry, I can see that you have your camera on. Do you have a question or comment?
Mainly, I just wanted to thank you for leading us in this conversation, and looking forward to meeting some of you as you're able to come to Dubai in June. And just wanted to say thank you. I think you covered so many different aspects of what we've done. And I've worked in schools a long time ago, and then recently, and then back in teaching now. So I just appreciate the time and the number of people who participated. So hurrah for y'all. That was great.
Thanks, Sherry. Well, thank you for those participants who have asked questions so far. We might just give it one more minute and see if there's any more questions, and otherwise we will draw a close to today's webinar, and we will post information up on the website later in the year after the World Congress is completed.
It's just a question in the chat, Nikki. Is the information open to all, or do you have to be a member of the IOPTP?
We do require participants to be from a member country of the IOPT. So specifically, the presentations have been put on free of charge for each of those members. At this point in time, no cost associated, but it is specifically directed at the members of the IOP. However, the IOP webpage is actually open to anybody on the internet, so they could search it and have a look.
Nikki, this is Barbara. Again, just the question often comes up, how do I become a member of the IOPTP? If you're a pediatric organization within your member country for WPT, for the World Confederation, the World Physio, if you're a member of the pediatric group, you are automatically a member. For example, if for the people in the US, if you're a member of the Academy of Pediatric Physical Therapy, you are automatically a member of the IOPTP through your membership for the Academy. Same thing in for any of our 32 member organizations. So you may be a member and you don't even know it.
That was just a nice comment in the chat, saying that there are no physiotherapists stationed in Japanese public schools, and that I think it is difficult to change Japanese education system, but there were some hints in today's lecture, so thank you.
Thank you, Sheree. Yeah, I think that those challenges exist all over the world, and I think if we just keep nudging this agenda a little bit more, and bringing more evidence to the conversation, that's only going to help us with this area of advocacy into the future. So thank you very much to everybody who's participated today, and a big thank you to our speakers today. Very much appreciate your time and input and expertise. Thank you, everybody. Hope to see you all at the next 6th webinar, which you will see advertised on the Friends of IOP webpage, and also the Friends of IOP Facebook page, and also on the IOP website in the near future. Thank you. If the